Hello, and welcome to the Pediatric Pharmacy Association's Core Competency Lecture Series. My name is Melissa Cook, and I am the clinical pharmacist in the Cardiac Intensive Care Unit at Children's Hospital New Orleans, and today I will be discussing ICU supportive care. I have no conflicts of interest to disclose in relation to this presentation. The learning objectives for today's presentation are to identify areas for potential drug-related problems in the Pediatric Intensive Care Unit, specifically recalling the mnemonic FAST HUG maidens, to summarize the pathophysiology, risk factors, and guidelines for several key aspects of ICU supportive care, including but not limited to nutrition, analgesia and sedation, thromboembolism and stress ulcer prophylaxis, delirium, and glucose control. And lastly, to use this information to provide dosing considerations and treatment recommendations in order to prevent drug-related problems within the ICU setting. Drug-related problems may lead to preventable morbidity, negative health outcomes, healthcare costs, and possibly mortality. The risk of drug-related problems has been illustrated to be increased in the pediatric population, especially within the ICU setting. The complexities of patient care in the ICU have been compared to that of an airline pilot in the cockpit, for which checklists are utilized to improve safety. Thus, in 2005, the mnemonic FAST HUG was developed by ICU physicians as a checklist to assess key aspects of patient care on a daily basis. This checklist has since been modified by clinical pharmacists to FAST HUG maidens to help identify drug-related problems in both the ICU and non-ICU setting. In comparison to the original mnemonic, FAST HUG, the H now stands for hypo or hyperactive delirium instead of head of bed elevation, and the second portion, maidens, was added. The FAST HUG maidens mnemonic was validated by assessing its utility in assisting pharmacy residents in identifying drug-related problems. Residents who used the checklist had a mean proportion of drug-related problems identified of 73.2%, compared to 52.4% in those who did not use the checklist. So how can this mnemonic or checklist be applied in a pediatric ICU setting for supportive care? I will be going over each letter and corresponding topic of the mnemonic in more detail, with the first up being feeding. Malnutrition is associated with adverse clinical outcomes, including prolonged ventilation, hospital-acquired infection, prolonged hospitalization, and increased mortality. The American Society of Parenteral and Enteral Nutrition recommend an initial detailed nutritional status assessment within 48 hours of admission, with routine assessment occurring weekly at minimum. Nutritional support therapy is the provision of enteral or parenteral nutrients to prevent or treat malnutrition. Enteral nutrition is preferred via the gastric route, but the postpyloric or small intestinal site may be considered for patients unable to tolerate gastric feeds or those at high risk of aspiration. Ideally, enteral nutrition is initiated within 24 to 40 hours of admission to the ICU. However, there are several circumstances that may serve as barriers to doing so, such as feeding intolerance, the need to fast around procedures, the use of vasoactive medications, or medical contraindications such as GI bleed or necrotizing enterocolitis. The goals of nutritional support therapy are focused on target energy and protein intake. Aspen's recommendations are listed for you there. Aspen has provided clinicians with guidelines for protein requirements dependent on the patient's age, including gestational age for infants, and clinical condition. The top table includes their general recommendations for protein goals in the different pediatric age categories, and the second table provides more specific protein goals in different clinical scenarios, such as during critical illness, acute kidney injury, or hepatic failure. Aspen does not recommend the initiation of parenteral nutrition within 24 hours of admission to the ICU. Instead, it is recommended to delay it until 1 week if the patient has a normal nutritional state at baseline or is at low risk of nutrition deterioration. That being said, parenteral nutrition may be initiated within the first week of admission for patients unable to receive any enteral nutrition or patients unable to have enteral nutrition advanced with severe malnutrition at baseline or at high risk for nutrition deterioration. Furthermore, early initiation of parenteral nutrition within 24 hours of admission should be considered for neonates and infants or malnourished patients if they're not expected to meet their goal within 72 hours of admission. Some pharmacotherapy considerations as it relates to feeding include the use of enteral versus parenteral nutrition. With enteral nutrition, pharmacists should consider switching to PO formulations, when possible, the various types of PO formulations available and what is optimal for the patient's route of feeds, and the potential alterations in drug absorption. With parenteral nutrition, pharmacists can intervene on appropriate laboratory monitoring, optimal composition of parenteral nutrition orders, drug shortage management of parenteral nutrition components, and to monitor for potential complications such as infection and thrombosis. The potential relationship of feeding intolerance and medication therapy may be due to adverse effects of certain medications, and feeding tolerance may be altered by the use of prokinetic agents for those with delayed gastric emptying. Also, the potential for interactions between medications and nutritional formulation should be considered. An infamous example of this involves warfarin and infant formula, given the difference in vitamin K amounts between breast milk and the numerous formulations on the market. I wanted to highlight a specific example of a drug shortage for which the pharmacist can have an impact on during the review of parenteral nutrition orders, and that is the IV multivitamin shortage. In order to maximize product utilization, aspirin provides recommendations for which patients should receive pediatric versus adult IV multivitamin in parenteral nutrition. The patient should be assessed for appropriateness of parenteral versus enteral nutrition and consider switching to an enteral multivitamin formulation when the enteral intake exceeds 50% of their needs, with the exception of patients with malabsorption. They recommend to reserve the pediatric formulation for children less than 2.5 kilograms or less than 36 weeks gestational age, and consider the use of adult IV multivitamin for children that are older or if the pediatric multivitamin is unavailable with the dosing strategy listed for you. If neither formulation is available, they recommend to administer components individually. Our next topic for discussion is analgesia. As you may recall, pain is unpleasant sensory and emotional experience associated with actual or potential tissue damage. Nociception is a process by which information about tissue damage is conveyed to the central nervous system. Our three most common types of pain include nociceptive, neuropathic, inflammatory pain. And the type of pain experience can be further described as acute versus chronic, which is distinguished by a duration of pain lasting shorter or longer than 3 months. To highlight a few key elements of the nociception pathway, the injury to one's tissue elicits an inflammatory response and release of mediators that help initiate pain signal transduction, including substance P, prostaglandins, serotonin, and acetylcholine. The pain signal is transduced through the peripheral nerves to the spinal cord and transmitted to the brain via the spinothalamic tract, where it is ultimately received as pain. In early 2022, the Society of Critical Care Medicine, or SCCM, published clinical practice guidelines on the management of pain, agitation, neuromuscular blockade, and delirium in critically ill pediatric patients, otherwise known as the PANDEM guidelines. The table before you provides a summary of recommendations included in the guidelines as it relates to analgesia, for which we will take a closer look. The assessment of pain can be difficult in the ICU setting, especially in pediatric patients based on whether or not they are communicative. For patients 6 years of age or older who are able to communicate, the SCCM guidelines suggest the use of one of the 4 tools listed. For non-communicative patients, they recommend the use of either the FLAC or Comfort B scales. Our goals of analgesia in the critically ill patient include pain relief, control of agitation, prevention of accidental removal of devices, to improve patient ventilator synchrony, to optimize hemodynamics, decrease oxygen consumption, and modulate stress response. In regards to the non-pharmacological treatment of pain, the SCCM guidelines recommend non-nutritive sucking with oral sucrose in neonates and infants prior to procedures, music therapy to augment analgesia in the post-operative patient, and parental presence at the bedside. For pharmacological treatment, the approach to pain management includes a multimodal approach with acetaminophen, nonsteroidal anti-inflammatory drugs or NSAIDs, opioids, and adjunct medications for varying levels of pain. The first class of analgesics to be discussed is the opioids. Opioids bind to opioid receptors to inhibit neurotransmitter release and neurotransmission via ascending pain pathways to alter our perception and response to pain. Class effects of the opioids include respiratory depression, hypotension, constipation and urinary retention, and nausea and vomiting. Fentanyl, hydromorphone, and morphine are three of the most commonly utilized IV opioids. They all have a quick onset of action and are renally eliminated. Fentanyl is metabolized via CYP3A4 to an inactive metabolite. It's a lipophilic molecule and has a potency of about 50 to 100 times that of morphine. Patients receiving fentanyl may experience tachyphylaxis with suboptimal pain relief despite increasing doses, especially in the neonatal and infant population. Both hydromorphone and morphine are metabolized via glucuronidation to active metabolites, which may have implications on the dosing required to achieve the same level of pain control. For example, with morphine, neonates and infants may require higher doses given its decreased metabolism to the most active metabolite, morphine 6-glucuronide. An adverse effect associated with morphine is pruritus due to mast cell degranulation and histamine release. Hydromorphone is about 3 to 10 times as potent as morphine and has been associated with pruritus, though to a lesser degree than morphine. Listed for you there at the bottom of the slide are additional routes of administration for each IV opioid discussed. This table is similar to the previous, but provides information for the PO formulations of hydromorphone and morphine, as well as oxycodone in lieu of fentanyl. Oxycodone is metabolized by CYP3A4 and 2D6 to active metabolites and should be used with caution in patients with known reactions to phenanthrene-derived opioids such as codeine, hydrocodone, and hydromorphone. Of note, similar to the previous slide, there are additional routes of administration for your reference at the bottom of the slide. We as pharmacists can help clinicians decide amongst these formulations based on what is most appropriate for our patients. The typical dosing for IV and PO opioids are listed for your reference on the next two slides, but may be titrated to effect, and these doses do not preclude clinical judgment for increased analgesic needs or adjustments based on clinical status. This slide serves as a reminder of the role of prostaglandins in the pain signaling process and how a few more of our medications elicit their analgesic effects. Acetaminophen blocks synthesis of prostaglandin in central nervous system to increase pain threshold. Notable adverse effects include rash and increased LFTs, and it is available in both oral and IV formulations, as well as a rectal suppository. Nonsteroidal anti-inflammatory drugs reversibly inhibit cyclooxygenase 1 and 2 enzymes to decrease the formation of prostaglandin precursors. Notable adverse effects include nausea, abdominal pain, an increased BUN and serum creatinine, bleeding, and decreased platelet aggregation. They are also available in oral and IV formulations. IV acetaminophen has been a hot topic over the last several years due to the mixed evidence of cost-benefit analysis, but studies have shown that it may reduce post-operative opioid usage, which is then associated with decreased morbidity and total healthcare expenditures. Looking at ibuprofen and ketorolac, one of the clinical pearls I specifically wanted to highlight is that while renal dose adjustment recommendations are available for ketorolac, it is still recommended to avoid both ibuprofen and ketorolac in the KDIGO guidelines. Also, while ibuprofen is not FDA approved in infants less than 6 months of age outside of PDA closure, many institutions will use it in patients 3 to 6 months of age and closely monitor if they are low risk for adverse effects or complications, especially in the post-operative setting for pain management. Moving on to sedation. Our goals of sedation in the critically ill child include to reduce anxiety, control agitation, prevent the accidental and removal of devices, improve patient ventilator synchrony, and to facilitate necessary care procedures. Again, here is the summary table in the SCCM guidelines I referred to earlier as it relates to sedation. The level of sedation can also be difficult to assess in critically ill children. There are several validated tools for use in pediatrics, including the Comfort B scale, the Stateford Behavioral Scale, and the Richmond Agitation Sedation Scale. While the use of a protocolized approach to sedation has not been found to be superior, the guidelines do suggest the use of a target depth of sedation with at least once daily assessment of sedation level. The first-line agent suggested in the guidelines for sedation in patients requiring mechanical ventilation is the alpha-2 agonists such as dexmedetomidine. Alternative sedatives include ketamine, benzodiazepines, and propofol, especially in the peri-extubation period. The next two slides serve as a reference for typical dosing of commonly used sedatives. However, again, it does not preclude clinical judgment for increased sedative needs. Dexmedetomidine has become increasingly popular due to the lack of associated respiratory depression compared to opioids and benzodiazepines, as well as a potential treatment option for cardiac surgery patients with tachyarrhythmias. Midazolam may be used as both an intermittent sedative or continuous infusion. In the setting of extracorporeal membrane oxygenation, it is sequestered by the ECMO circuit due to its lipophilicity and high degree of protein binding, resulting in higher initial doses needed for appropriate level of sedation. Lorazepam, another benzodiazepine, is predominantly used as an intermittent agent, especially in the pediatric population due to the potential for propylene glycol toxicity with the IV formulation. Ketamine and propofol are general anesthetics that may be used as alternative sedation strategies. Ketamine has been shown to increase salivary secretions and is associated with a risk of emergency reactions with discontinuation, but it may be a good option in patients with hypotension with other sedative agents. Propofol has a risk of propofol-related infusion syndrome, but can be reduced when used with a duration of less than or equal to 48 hours and doses less than 67 mics per kilo per minute. But it is important to note that doses required are much higher in the pediatric patient, especially young children, compared to that of adults, and might put patients at higher risk for PRIS. Next up is thromboembolism prophylaxis. Venous thromboembolisms, or VTEs, are preventable conditions that are associated with an increased morbidity and risk of mortality. Incidence of VTEs within pediatric ICUs has been increasing over the last few decades, with a reported incidence ranging from 0 to 2.7%, as depicted by the table below. Of note, this might be an underestimation of the true incidence, as the investigators only included patients who developed symptoms related to VTE. Regardless, this rate has increased from 0.49% between 1979 to 2001 and 0.34 to 0.58% between 2001 and 2007. The highest incidence of VTE in children is within the neonatal and adolescent population. The risk factors associated with the development of VTE have been described using Higgerson and colleagues evaluated the potential risk factors for VTE in the pediatric ICU. They found the following variables in the table before you to be associated with an increased risk of VTE development, with the presence of a central venous catheter having the greatest risk. There are a few guidelines available regarding the use of thromboembolism prophylaxis. In 2012, the American College of Chest Physicians published guidelines for antithrombotic therapy in neonates and children. These guidelines recommend the use of heparin to maintain patency of various catheters, as well as provide more specific recommendations for treatment of VTEs. In 2017, the Pediatric Trauma Society and Eastern Association for Surgery of Trauma published guidelines that recommend patients receive pharmacological and mechanical prophylaxis in children greater than 15 years of age and younger post-pubertal children with an injury severity score greater than 25. The 2020 Pediatric Surviving Sepsis Campaign guidelines suggest against DVT prophylaxis in patients with septic shock or other sepsis-associated organ dysfunction, but recognize that potential benefits may outweigh the risks and costs of VTE prophylaxis in specific populations. Lastly, the 2021 Adult Surviving Sepsis Campaign guidelines conversely recommend routine pharmacological prophylaxis with low molecular weight heparin over unfractionated heparin in patients with sepsis or septic shock. When considering whether or not we should initiate VTE prophylaxis, it is important to note that practice varies amongst institutions. A survey of VTE prophylaxis practices in PICUs across the United States and Canada illustrated just that. 60% of PICUs had informal policies, written guidelines, or orders for prophylaxis, which resulted in an increased likelihood of prescribing prophylaxis. 42.3% of PICUs commonly prescribed VTE prophylaxis in the adolescent population, but the rates were significantly lower in that of the younger populations. Major risk factors determining the use of VTE prophylaxis included hypercoagulability, a history of DVT, or the presence of a cavopulmonary anastomosis. And the most common anticoagulant utilized was low molecular weight heparin. Another factor limiting the national standardization of VTE prophylaxis is the lack of a validated risk prediction tool in the pediatric population. The PEDS Clot Clinical Decision Rule, or the PCDR, was developed in an attempt to assist clinicians in identifying high-risk patients. The authors conducted a case control study using a derivation and validation sample from different pediatric hospitals to determine its utility. Investigators assessed patients for 6 risk factors that are listed in the table on the right and assigned points as outlined. A score of 3 points or higher was indicative of high risk for VTE development. Upon application of the tool to the validation sample, they determined it to have a sensitivity of 57%, specificity of 88%, and an area under the ROC curve of 0.875, which was statistically significant. The authors concluded that the PCDR was useful in identifying patients at high risk for VTE development, but large-scale prospective validation is needed. The next few slides provide an example of an institutional-based guideline for VTE prophylaxis. These specific guidelines use an age cutoff of 14 years to begin their risk assessment. The guideline continues to outline what interventions should be utilized for patients deemed candidates for pharmacological prophylaxis based on their risk assessment results. These tables are included in their guidelines to provide clear definitions and risk factors, as well as dosing recommendations for pharmacological prophylaxis. This dosing table for prophylactic agents is for your reference. Both heparin and enoxaparin are renally eliminated, but there are no specific recommendations for dose adjustments. Routine monitoring for VTE prophylaxis is not required, but may be warranted in special populations such as those with obesity. It is important to note that the Joint Commission requires hospitals to have protocols surrounding anticoagulation, but as mentioned previously, there is wide variation in clinical practice. We will now switch gears to delirium. Delirium is defined as a syndrome characterized by the acute onset of cerebral dysfunction with a change or fluctuation in baseline mental status, inattention, and either disorganized thinking or an altered level of consciousness. The incidence of delirium is described as 10 to 30% among critically ill patients, but is not well understood in the pediatric population. Delirium has been shown to be associated with an increased length of stay and costs, neurocognitive impairment, as well as an increased mortality. Several mechanisms have been described regarding the pathophysiology, but there are 3 key players involved that lead to disrupted neurotransmission. These are systemic inflammation, which leads to increased levels of cytokines within the brain, acute stress response, which may result in hypoxemia, and metabolic derangement, which, when paired with global impairment of cerebral metabolism, leads to decreased synthesis and release of neurotransmitters. And lastly, drug toxicity, such as that from our benzodiazepines, which cause an imbalance in neurotransmitters and disrupt synaptic communication. Delirium is diagnosed using the DSM-5 in conjunction with a psychiatry consult and one of the following screening tools: the Preschool Confusion Assessment Method for the Intensive Care Unit, or PSCAM ICU, the Pediatric Confusion Assessment Method for the Intensive Care Unit, or PCAM ICU, or the Cornell Assessment of Pediatric Delirium, CAPD. Delirium can be categorized into one of 3 subtypes, such as hyperactive, which is characterized by agitation, hallucinations, and delusions; hypoactive, which is characterized by lethargy, confusion, and sedation; or a mixed subtype, which is a fluctuation between the hyperactive and hypoactive subtypes. Looking more closely at the Cornell Assessment of Pediatric Delirium tool, this is a rapid observational screening tool for delirium that has been studied in children of all ages with and without developmental delay. A total CAP-D score of 9 or greater was associated with delirium, and overall was found to have decent sensitivity and specificity, but can be further evaluated for utility in special patient populations. The PANDEM guidelines provide recommendations for screening and treatment of delirium that are summarized in the table before you. More specifically, the guidelines suggest the use of non-pharmacological treatment to prevent or reduce the severity of delirium symptoms. These include providing a calm and reassuring and familiar environment, considering room location based on subtype of delirium, early mobilization of the patient, developing a routine schedule to promote sleep-wake cycles, and encouraging family involvement in patient care. It is not until patients are considered to have refractory or severe delirium that these guidelines suggest the use of pharmacological treatment with antipsychotics. Antipsychotics have a wide variety of mechanisms, including the antagonism of dopamine, serotonin, histamine, and adrenergic alpha receptors in the brain. The affinity for each receptor depends on the agent selected, and these are listed for you in the image to the right for each antipsychotic with the affinity and receptors antagonized by each medication. Class effects of antipsychotics include QTc prolongation and sedation. The atypical antipsychotics most commonly prescribed are quetiapine, risperidone, and olanzapine. Quetiapine may be used for all subtypes of delirium, whereas risperidone is best utilized for hypoactive or mixed subtypes, and olanzapine is best for hyperactive subtype. They can all be titrated to effect pretty quickly and come in oral formulations, with the additional option for IM dosing with olanzapine and IV or IM dosing for haloperidol, which is a typical antipsychotic. The dosing for each antipsychotic varies among patient populations and can be used in both weight-based or non-weight-based strategies. For example, risperidone is largely prescribed using non-weight-based doses, but has recommended max doses based on weight cutoffs. A patient weighing less than 20 kilograms has a recommended max dose of 1 milligram, 20 to 45 kilos is 2.5 milligrams, and patients weighing more than 45 kilograms have a recommended max dose of 3 milligrams. Antipsychotics have been associated with QTc prolongation at a reported incidence of up to 40% of patients admitted to the hospital. Patients admitted to the ICU are at an increased risk of arrhythmia secondary to QTc prolongation due to the concomitant use of multiple QTc prolonged medications, electrolyte disturbances, and altered drug disposition and metabolism. The degree of QTc prolongation with antipsychotics when used for delirium in the pediatric ICU was reviewed, and investigators observed a median difference in QTc interval of only -4 milliseconds, with an interquartile range of -29 to 11 milliseconds. They also found that none of the evaluated risk factors were associated with a change in QTc interval in this cohort, so the clinical significance of QTc prolongation in antipsychotics is still yet to be fully elucidated. Next up is stress ulcer prophylaxis. We know that critically ill patients are at risk for ulceration due to physiologic stress, impaired mucosal defense, and ischemia. The prevalence of clinically important bleeding associated with ulceration is reported at 1.5 to 2.6%, with risk factors for bleeding including coagulopathy, which is defined as a platelet count greater than 50,000, an INR greater than 1.5, and a PTT greater than 2 times the control value, coexisting diseases, high organ failure score, liver disease, maximum serum creatinine, the use of renal replacement therapy, and respiratory failure as defined by a need for mechanical ventilation. The ASHP and Eastern Association for the Surgery of Trauma guidelines provide specific patient populations for which stress ulcer prophylaxis is recommended, but do not indicate a preferred agent. The Adult Surviving Sepsis Campaign guidelines recommend stress ulcer prophylaxis for patients with sepsis or septic shock and risk factors for bleeding, whereas the pediatric guidelines recommend against routine prophylaxis, with the exception of high-risk patients, which include those listed here. Another guideline not included in this presentation, published by the Danish Society of Anesthesiology and Intensive Care Medicine in 2014, recommends against the routine use of stress ulcer prophylaxis, but suggests the use of a PPI when clinically indicated. Stress ulcer prophylaxis is commonly used despite the lack of strong evidence for benefit and the optimal therapeutic regimen identified. The goal of stress ulcer prophylaxis is to reach a gastric pH level greater than 4, and common treatment options include H2 receptor antagonists and proton pump inhibitors, or PPIs. For sake of time, I will not be going through each of these meta-analyses in great detail, but I wanted to highlight that the risk of bias, statistical analysis, and differences in study setup limit the results for each study. There remain mixed results regarding the benefit of stress ulcer prophylaxis, thus we continue to lack a clear recommendation for clinical practice and remains variable amongst institutions. The dosing for commonly used acid suppressants is included for your reference. Some agents are only available in PO formulations, so many institutions must maintain different formulations or options within each drug class on formulary. Our next topic of discussion is glucose control in the ICU setting. Dysglycemia is common among critically ill patients and is a multifactorial process associated with stress of acute illness. Patients may experience not only hyperglycemia, but hypoglycemia and glucose variability as well. It is evident that dysglycemia is associated with negative outcomes, including prolonged length of stay, neurological impairment, and mortality. The development of dysglycemia is a multifactorial process that involves several different hormones, pro-inflammatory mediators, and impaired glucose control. Glucogenolysis, or the breakdown of glycogen into glucose to provide energy and maintain glucose levels, is primarily caused by catecholamines and cortisol. Gluconeogenesis, or the generation of glucose as an alternative source to breakdown of glycogen, is a result of glucagon. There is an inadequate uptake of glucose by the skeletal muscle and adipocytes due to alterations of insulin signaling and results in downregulation of type 4 glucose transporters. Ultimately, dysglycemia in the ICU setting is a downstream effect of critical illness, and simply correcting blood glucose levels does not address the underlying problem at hand. The use of tight glucose control parameters has been studied in both the adult and pediatric populations. A systematic review and meta-analysis of randomized controlled trials of tight glucose control in the critically ill child was published in 2018. The authors defined tight glucose control when identifying studies was a glucose goal of less than 140 milligrams per deciliter obtained by using insulin treatment, but the specific goal utilized varied amongst trials and are outlined on the following slide. They reviewed 6 studies with the primary outcome of mortality, and secondary outcomes included hypoglycemia, sepsis, new need for dialysis, and seizures. Based on the compilation of study results, the authors concluded that the use of tight glucose control did not significantly reduce mortality and put patients at an increased risk of hypoglycemia. The 6 studies included varied and specific blood glucose targets, but 8100 was commonly utilized. Based on the available literature, the current guidelines for glucose control recommend against utilization of tight blood glucose control. Instead, the American Association of Clinical Endocrinologists, the American Diabetes Association, and Adult Surviving Sepsis Campaign guidelines recommend a target glucose level of 140 to 180 milligrams per deciliter with initiation of insulin therapy when blood glucose levels exceed 180. For pediatric population, the Surviving Sepsis Campaign guidelines do not provide a target blood glucose range, but do recommend against a level less than 140. When insulin is initiated for hyperglycemia, it is recommended to use regular insulin at a dose ranging from about 0.01 to 0.1 units per kilo per hour or more as needed to maintain our blood glucose target. The use of insulin therapy should be closely monitored to prevent severe abnormalities in blood glucose and electrolytes such as hypoglycemia and hypokalemia. Potential drug interactions with insulin include beta blockers, thiazide diuretics, and fluoroquinolones. Shifting gears a bit, the second portion of the mnemonic is maidens, which largely relates to the medication use process. It is recommended to review ordered medications upon admission transfer between units, and prior to discharge to ensure the patient's medication list is up to date and appropriate. A medication history may be obtained from the patient, a family member or caregiver, the outpatient pharmacy used by the patient or family, the ordering physician, as well as medical records, and should include an assessment of not only prescription medications, but over-the-counter medications, herbal and/or vitamin supplements, and illicit drugs. Patients admitted to the ICU are at a high risk for acquiring an infection, if not the reason for admission. Pharmacists can play a major role in antimicrobial stewardship and assist with both the selection of the optimal antimicrobial agent and recommending an optimal dose of therapy. The selection of an optimal antimicrobial agent should consider a patient's medical history, organ function, recent anti-infective use, and/or hospital admission, as well as the utilization of culture and susceptibility results to tailor therapy upon initiation and throughout the course of therapy. Polypharmacy is common in the ICU setting given the critical and dynamic clinical status that necessitates frequent changes in therapy. It is important as pharmacists that we are reviewing both scheduled and as needed medications for an appropriate indication of therapy. We can have an impact on patient outcomes, prevention of adverse effects, and cost savings by discontinuing medications without an indication or upon completion of therapy, such as the discontinuation of stress ulcer prophylaxis when no longer at risk for bleeding, or when we complete antibiotic therapy. Another opportunity for impact is with the assessment for under or untreated conditions for which we may need to add or modify therapy. As pharmacists, we play an important role in determining the appropriateness of drug dosing, which should include a continual assessment for pediatric considerations, such as adjustments for developmental pharmacology, organ dysfunction, including both renal and hepatic adjustments, and therapeutic drug monitoring when applicable. Please refer to the renal development and dose adjustments as well as pharmacokinetic presentations for more detailed information. Another area in which we as pharmacists can be impactful is with the assessment of drug-related adverse effects, including those associated with lab abnormalities. We can apply our drug expertise to provide medication regimen modification recommendations or suggestion of alternative therapies when current therapy becomes suboptimal or problematic in our patients. Additional risk for drug-related problems is with potential drug interactions, allergies, duplications of therapy, and potential adverse effects. Pharmacists should assess for not only drug-drug interactions, but should consider potential interactions between drug and food as well as drug and labs. Allergies should be assessed to determine if it's a true allergy, intolerance, or adverse effect with a medication, and documented appropriately in the electronic health record. Duplication of a drug class or indication can result in an adverse effect and may be discordant with Joint Commission standards if not clearly stated what the indication and administration instructions should be, such as with as-needed analgesics and sedatives. Reported symptoms may be associated with a medication, thus pharmacists can help review a patient's medication regimen for possible offending agents. The Joint Commission has established medication management standards that further support the need for pharmacists to assist with medication review to identify current or potential allergies or sensitivities, drug interactions, current medications, appropriateness of therapy, impact on laboratory values, therapeutic duplication, and contraindications to therapy. Any concerns, issues, or questions regarding medication therapy should be clarified with the ordering provider prior to verification and dispensing of the medication to the patient. Lastly, in conjunction with identifying indications for medications, it is important to determine an appropriate duration of therapy. We can prevent too long of durations, such as those associated with default durations in the electronic health record, as well as too short of durations, such as those associated with order entry errors. As with other order parameters, the duration of therapy should be continued to be assessed throughout a patient's admission. In summary, the risk of drug-related problems is increased in the pediatric population, especially within the ICU. Pharmacists can identify potential drug-related problems as it relates to ICU supportive care using the mnemonic FAST HUG maidens, which incorporate key aspects of ICU supportive care and medication therapy management. Use of guidelines is crucial in standardization of care and prevention of medical errors, and institutions might need to implement local evidence-based guidelines if consensus guidelines are not available for use. The next few slides include my references for this presentation. And now we will move on to the assessment questions. Question number 1. What does the F represent in the mnemonic FAST HUG maidens? Is it A, fever, B, fine motor control, C, feeding, or D, fracture? Answer is C, feeding. Question number 2. Which of the following mediators involved in the nociception pathway may be targeted with pain management therapies? Is it A, prostaglandins, B, histamine, C, opioid peptides, or D, both A and C? Answer is D, both A and C. Question number 3. Which of the following statements regarding ICU supportive care therapies is true? A, the 2022 SCCM Pandem guidelines recommend dexmedetomidine as first-line therapy for sedation in critically ill children based on the evidence of reduced duration of mechanical ventilation, ICU length of stay, tachyarrhythmias in cardiac surgery patients, and exposure to benzodiazepines and opioids. B, protocols for thromboembolism prophylaxis are a requirement of Joint Commission, but remain widely variable among institutions due to the lack of clear consensus guideline recommendations in critically ill children. C, the Pediatric Surviving Sepsis Campaign recommends against routine stress ulcer prophylaxis in patients with septic shock or other sepsis-associated organ dysfunction. Or D, all of the above. The correct answer is D, all of the above. Question number 4. A 5-year-old female weighing 21.3 kilograms with developmental delay admitted to the PICU has required a prolonged course of sedation with benzodiazepines. She is screened for delirium given her fluctuations in agitation and has a CAPD score of 11. The medical resident comes to you for help with an assessment of her CAPD score and treatment recommendation if applicable. What is your response? A, her CAPD score is above the threshold of 9 and may require treatment if refractory to non-pharmacological therapies. Consider risperidone at an initial dose of 0.5 milligrams at bedtime with a max dose of 2.5 milligrams based on her weight. B, her CAPD score is above the threshold of 7 and may require treatment if refractory to non-pharmacological therapies. Consider risperidone at an initial dose of 0.5 milligrams at bedtime with a max dose of 1 milligram based on her weight. C, her CAPD scores below the threshold of 20 and does not require treatment. Or D, CAPD scores are not recommended for patients with developmental delay and thus treatment recommendations cannot be made. Correct answer is A. And lastly, question number 5. A recent systematic review and meta-analysis of randomized controlled trials of tight glucose control in critically ill pediatric patients concluded that tight glucose control should be implemented in the ICU given its mortality benefit without risk of severe hypoglycemia. A, true, or B, false? Answer is B, false. And with that, we conclude today's presentation on ICU supportive care. Thank you for your time.